Hi, it's Yuri, and welcome back to Physiology. And what I hope you're going to do is take very seriously everything that we study. And by serious, I don't mean grim. I mean, expect that you should have to read in advance, go through the slides, and read again. Now we're going to be adding some extra qualities to the slides so that we're not just reading the slides to you. You can read the slides to yourself. So we'll be doing some extras around the edges and adding in a little clinical things, here and there. And there is a lot of clinical material that can come out of fluid distribution and edema. This is my first lesson for you, and I hope you'll enjoy it. The majority of our body water is inside the cell or outside the cell. Well, the majority is inside the cell. The intracellular fluid volume is 2/3 of the total body water. Now, 1/3 of the total body water is outside. The interstitial fluid makes up about 3/4 of that extracellular fluid, and 1/4 of the fluid is in the plasma volume. It's really tiny, isn't it? It's amazing how little of our body fluid is actually plasma volume, meaning that the entirety of our 5 liters, so that plasma is really the tiniest amount. It's like 1/4 of a third. The blood volume is the smallest part of us. Now, this picture is a graphic representation of what I just said. It says the same thing twice. 2/3 of our body water is intracellular. 1/3 is extracellular. Of the 1/3 that's extracellular, 3/4 is interstitial. And only 1/4 of the extracellular fluid volume is in the vascular volume. It's really tiny, isn't it? Now, 60% of men is water, and 50% of women are water. That is because men have less fat and more muscle mass. But the greatest determinant of your body fluid compartment is your fat component. So let's say, if you're 50 kilograms, but 60% of you is fat, you have less water. The larger the fat, the less the water. The driest part of you is the fat. And actually, fat has less water than bone. Bone has more water because there's blood vessels in it. It's really amazing, isn't it? Now we're going to the concept of osmosis. Osmosis is the way that we move things between the compartments. In other words, you need a semi-permeable membrane. If it was fully permeable, there'd be no osmotic difference. A fully permeable membrane doesn't allow there to be an osmotic difference. So how could there be something that is an osmotic gradient or difference or tone if everything is equal? And at the same time, if it was completely impermeable, there'd be no draw up because there'd be no chance of getting there. Water diffuses from a region of higher to lower water concentration. So keep it in mind that it's about the water concentration if you want to grasp this concept. Because there is a semi-permeable membrane that allows it to go across. So if it was completely permeable, there'd be no osmotic gradient. If it was impermeable, you wouldn't be able to do anything about it. You wouldn't feel it. It's so impermeable so that nothing could get across. The greater the solute concentration, the lower the water concentration. The osmotic properties don't spend a whole lot of time worrying too much about the difference between osmolarity and osmolality. So we tend to use those terms interchangeable because, after all, a liter of water is the same thing as a kilogram per liter, right? From physics class. And that's why a liter of water, a kilogram of water is the same thing. 1 liter of water weighs a kilogram. 1 kilogram of water is a liter. So we use the terms interchangeably. And most of the faculty don't think it makes any difference at all. This is just to tell you, don't worry about the difference. They're used interchangeably and it's okay. Well, your books will also have a picture of osmotic gradients. But the most important thing for you to recognize is that the red line is in the center is semi-permeable. It's impermeable enough for water to go across, but not so permeable that it lets the solutes go across. And that's why this is an example of a semi-permeable membrane that allows you to have an osmotic gradient, because it allows only some things to go across. And the reason that one channel is higher than the other is because that's a tonicity. It's a force, it's a power, that's an osmotic pressure of gradient. An effective osmole is a solute that doesn't cross the membrane. That's why it's effective. If it went across easily and was equal everywhere, it wouldn't be effective because everything would be equal. It has to be an unequal osmotic particle. Unequal. More on one side than the other, like plasma proteins. They don't cross easily, so they effectively serve to hold fluid in the vascular space. Albumin holds fluid in the vascular space. I have a patient right now. She needs a bad surgery. She needs a big surgery, but she's very malnourished. So the surgeons won't operate on her until her albumin goes higher. So they have to feed her up, feed her up, feed her up, because they're afraid that all of her fluids will be lost from the vascular space. So eventually she'll have a dangerous hypotension. So all of these things that we think of are miscellaneous facts for exam are vitally important actually. And what happens in the mind of students is they start to say, it ain't real. It's a bunch of crap for a test, it's not real, but it's real. Plasma protein levels have to be high enough to maintain blood pressure. Sodium doesn't penetrate as much as water, so it will cross some capillary membranes, but it won't penetrate things like the cellular membrane. That's why sodium ends up being largely an extracellular particle, because it doesn't penetrate easily into the intracellular space. This is why if we have to do a lot of paracentesis on a patient who has a lot of ascites to remove, you can give them albumin in the vasculature, albumin in the blood vessel to keep the fluid in the blood vessel. And a smaller gap is important clinically when we think somebody has taken an overdose. So once I was in the intensive care unit and the person took an overdose of an unknown substance. And we figured that out because we measured her osmolarity to be 400. But when we calculated it, it came out at only 300. So what's the extra 100 in there? It's kind of like you're leaving the store and you have a receipt for $20 worth of stuff, but we find $100 worth of stuff in your car. Well, you get the other 80. Where did you get the other 80 bucks worth of stuff for a hand? So remember, the largest component in the osmolarity should be the sodium, 2 times the sodium. As a matter of fact, 2 times the sodium plus 10, because in a normal glucose there are 80 or 100. So that only means 4 points from the glucose, 3 or 4 points from the glucose, as a matter of fact. And the normal BUN is only around 10 or 15, about 3 points to the area. So really, most osmolarity is 2 times the sodium plus 10. But that means the biggest component of extracellular fluid, osmolarity. And remember, don't get worried about osmolarity. Osmolarity is sodium. So if you measure it and you find there's a lot more, it means there's an extra osmole in there. Methanol, ethanol, ethylene glycol. Methanol is a type of alcohol that's wood alcohol. It's used to be using that in the past for desperate alcoholics. By the way, don't really try to focus on this formula. You'll forget it, I'm sure. The most important part is for you to understand that the main osmole is sodium, and anything you find extra is something from this, like ethanol, methanol, and so on. And ethylene glycol comes out of antifreeze, also very important substance. Ethylene glycol poisoning was not responsible for the creation of Food and Drug, was responsible actually for creating the Food and Drug Administration. So mannitol is used mostly therapeutically. There is no overdoses of that. But the Osmolar Gap requires you to know just to calculate it. Changes start in the extracellular fluid first. It starts actually in the plasma first. Changes start either up or down in the extracellular fluid volume. Symptoms tend to be intracellular, but changes are first in the extracellular. Looking at the concentration of the solutes are equal to body osmolality. And basically things do come to steady state. Now, they may not have the same constituents. For instance, you have all of your chloride. Well, mostly that's the equal, but you tend to have your sodium in the outside and your potassium on the inside. But the total number of particles is the same. In other words, outside the cell, sodium up, potassium low. Inside the cell, sodium low, potassium up. But the total number of osmolar particles has to be equal. Other than that, we wouldn't be able to live. Which particles? Different. Total number? The same. So the body compartments is an extracellular fluid volume. Well, this varies with the effect of osmolarity. Sure, why? Because it moves things across, man. If I increase the effect of osmolarity of the extracellular fluid, it will dry out your cells. If I decrease the osmolarity of the extracellular fluid, it will swell your cells. So solutes and fluids enter and leave extracellular compartment first, and the intracellular volume is only altered if the extracellular osmolarity changes. So intracellular is as an effect of the changes outside the cell. Changes start in extracellular. We put IV fluids into your vein. Into your vein means extracellular, but the changes later are intracellular. So if you inject D5W or normal saline into your vein, that's an extracellular fluid change. So we have to know what swells and shrinks and swells. Extracellular fluid osmolarity increases, it tends to shrink the cells, drives them out like putting salt from the outside of the fish. When extracellular fluid osmolarity decreases, the cells swell. Well, you can see it in the image. Another way of knowing it is the top one says hypertonic and the bottom one says hypotonic. Shrink, swell with a great picture. That's a great picture. Darrow-Yannet diagram is just a name applied to being able to understand the graphical form. Solute concentrations up and down and fluid volume concentrations are left and right. This is a standard way of just saying, well, look, intracellular fluid is 2/3 and extracellular fluid is 1/3. and saying, looking at the osmolarity concentrations, is the red line. The dotted red line, it is at a high or low osmolar content. This red line is a low osmolar content. It is lower than normal, lower than the normal osmolarity of 300, and just represents it in graphical form. And in this diagram, is the fluid volume increased, decreased, or the same? The volume is decreased. Is the osmolarity increased, decreased, or the same? The osmolarity is the same. This is a loss of extracellular fluid volume. This would be like someone who's had a big sweating or just had blood loss. This is basically blood loss. But it's saying, I can tell by just a glance that this would decrease an extracellular fluid volume, with the intracellular volume staying the same. So on this image, is there an osmotic difference in this diagram? Is there any osmotic difference? The answer is yes. There is an osmotic difference here. The osmotic difference is that the osmolarity goes up and the volumes of both compartments are down. Volumes are down, osmolarity is up. Extracellular on the right, intracellular on the left. This is a person who's just dry. It's a person living in a microwave or oven. This is a net loss of water in both compartments. Both compartments are just dry. So is the osmolarity up or down? The osmolarity is up. The reason it's up is also because they become equal after a while. Yes, both compartments do equalize actually. This is a net gain of solute. The osmolarity is up, and it's also taking water out of the intracellular space. People who get salt ingestion, people who take salt tablets over time, people who get mannitol and basically dries out your intracellular fluid volume. This is a person who's a pickle. This is a person who's been pickled and their intracellular fluid volume is down. This is also why salt ingestion causes hypertension. You notice how the osmolarity goes up, but also the volume goes up. And outside the cell with the extra salt. And this is why high salt intake causes hypertension. Because it pulls fluid into the vascular component and raises blood pressure. That's why one of the reasons that we restrict salt in treating hypertension. The osmolarity here in both compartments is down. You see how the osmolar changes always equalize. Osmolar changes always have to equalize, and this is a person who's got more volume in both compartments. There is a lot of water that's equalized. So if you drank a lot of water over time, it would equalize, and this is also why there is no edema in CIDH, because both compartments go up. When both compartments go up, you don't have edema. So there is a low osmolarity of both compartments like in CIDH. There is a low osmolarity of both compartments like a person who's just drinking a lot of water. Now, this is a person who's drinking too much Gatorade. This is a person who has this isotonic fluid ingestion. This is a person who's gaining fluid like you drank a ton of saline, like you had a lot of Gatorade, and basically the osmolarity stays equal. Between the intracellular and extracellular fluid compartments, the osmolarity is equal, but the volume on the extracellular component is up. The volume outside the cells is up because you're ingesting isotonic fluid. Now you can see how both compartments end up with an equal osmolarity, because you have to become equal or you die. But this is an example of a person whose intracellular fluid volume is increased at the expense of their plasma volume. This is an intercellular fluid volume increase. So what's losing here is you're losing both salt and water. You're losing both salt and water of the extracellular volume. Salt and water like in a person who's got Waterhouse-Friedrich syndrome or Addison's disease, where you lose the adrenals on autoimmune or infectious basis, and you lose both volume and you lose the salt because you don't have aldosterone. Well, how do we regulate volume? Aldosterone, actually one of my favorite hormones, increases sodium reabsorption of the principal cells. It's also with the potassium happens, isn't it? So it increases sodium and excretes potassium at the principal cell. And the extracellular fluid volume gets maintained here. Not instantly because aldosterone needs time. Principal cells absorb sodium and excrete potassium. And over a day, they will maintain your volume. The number one thing that regulates aldosterone from where? So it's the zona glomerulosa. It's under the control of angiotensin II. This slide describes volume regulation also by antidiuretic hormone. Now, what do you mean AVP? AVP means actually arginine vasopressin, like an alternative name. So it's the same as antidiuretic hormone. Arginine, vasopressin. So what's the difference? Antidiuretic hormone is basically the volume change based on a 1% change in osmolarity. It changes the volume. A 1% change in osmolarity increases ADH. Arginine vasopressin is the same substance at higher amount and makes you have a vasoconstriction. ADH makes you reabsorb just the water at the cells and the V2 receptors in the collecting duct and therefore maintains osmolality. V1 receptors in arterioles causes vasoconstriction. V1 receptors in arterioles maintain vasoconstriction and maintain vascular tone. And the major regulators of ADH is a 1% change in osmolality detected in the hypothalamus or a 10% change in volume detected at your carotids. Volume at your carotids and osmolality at your hypothalamus, right? 1% change in osmolality, it's ADH. 10% change in volume, vasopressin. So the renin-angiotensin-aldosterone system is an indispensable must-know subject. So the juxtaglomerular complex senses hypotension. Also, it senses beta stimulation and makes renin. Renin converts angiotensinogen to angiotensin 1. So it regulates the angiotensinogen to angiotensin 1. And then angiotensin 1 is converted to angiotensin 2 in the lung. And the primary regulators, low perfusion of the kidney, beta 1 also makes it go up and also decrease sodium in the macula densa. So again, low perfusion of the kidney, sympathetic stimulation through beta 1, and decreased sodium delivery in the macula densa. See, if the macula densa picks up less sodium, it means it's going to make aldosterone eventually to absorb the sodium. A low sodium leads to sodium absorption, which makes sense, right? High potassium hits the aldosterone, makes you excrete potassium. So it's homeostasis. Whenever something goes up and down, the body regulates somehow the hormones so that it eventually comes to balance. There is some negative feedback in regulation of this as well, where aldosterone increases sodium reabsorption and increases also the extracellular fluid volume. Yeah, and the renin is stimulated by low blood pressure at that juxtaglomerular complex. So aldosterone is one of the main regulatory mechanisms for low blood pressure. Now, in the microcirculation, the fluid flux across the capillary is governed by a certain hydrostatic pressure. Pressure of the fluid going across fluid flux. And the hydrostatic pressure makes you go across, makes you lead. That's your biggest mantra. Okay, so filtration is the same thing as hydrostatic pressure making pressure leave, making fluid leave a blood vessel. Oncotic pressure, largely provided by proteins, opposes filtration. Opposing filtration with oncotic pressure is the same thing as saying favoring reabsorption. Opposing filtration means favoring reabsorption. So oncotic pressure opposes filtration and favors reabsorption. Filtration means leaving the plasma, going to the interstitium. So what's your greatest factor favoring filtration? Hydrostatic pressure. Absorption means going the other way. Opposing filtration is the same thing as saying favoring reabsorption. The greatest stimulant to filtration is hydrostatic pressure in the capillary, and the greatest stimulant to reabsorption is the oncotic pressure in the capillary. The major force for filtration is the hydrostatic pressure in the capillary. It's directly related to blood flow and venous pressure and blood volume. The more blood flow, the greater the pressure, the more there is hydrostatic pressure, and the more it leaves. Oncotic pressure is the force that's in the interstitium. It pulls it out. However, oncotic pressure in the interstitium is just not as important as hydrostatic pressure in the capillary, because there's just less of it, less of a number. Oncotic pressure in the interstitium pulls fluid out. Hydrostatic pressure in the capillary pushes the fluid out. Hydrostatic pressure in the capillary pushes the fluid out. Oncotic pressure in the interstitium pulls. And it's from a small amount of proteins that leak. And you can understand that it's small because not only does small amount leak, the lymphatics pick it up and remove it. So under most conditions, it's just not a big deal. The major force for absorption or reabsorption is oncotic pressure in the plasma. That is one is important. Plasma proteins don't diffuse across. You see how this is a semi-permeable membrane? None of these forces would have any effect at all if it was completely impermeable. No matter how cute you are, a blind person is not going to see you. So the thing is, if it was completely impermeable, you're not going to have any effect at all. So albumin is the most important plasma protein and the biggest contributor to this force. So the hydrostatic pressure in the interstitium is less important simply because it's smaller. Hydrostatic pressure in the interstitium opposes filtration, favors reabsorption. Opposes filtration is the same as saying favoring reabsorption. And hydrostatic pressure in the interstitium is generally close to zero. Now, this is Starling equation, different from the Frank-Starling forces of the heart. It summarizes everything that we said. I always thought that formulas or equations are actually useless to just trying to remember them, because you're gonna forget them. Let's be honest. But when you can grasp the principle, when you understand how things work, you can actually deduce or write the formula by yourself by not even remembering it, but just taking from the fact that you know how things work and having the basic concept of math, you can actually write the formula yourself. So the only new thing that's extra, it's K, which is a constant. That's diffusion coefficient actually. It's a feature of the tissues. Some tissues are just more permeable than others. So like tissue paper, more permeable than a brick. So, and you can only change that if you somehow change the feature of the blood vessel. For instance, if you get burned or inflamed, you end up having a greater coefficient of filtration because you've changed the blood vessel mechanics, the structure. The permeability of the tissue can change the permeability over all fluids. That's a feature of the tissue, and minute to minute that does not change. That K only changes under disease conditions. Lymphatics pick up proteins in the interstitium. This is why the interstitial protein level is not a very important feature of the forces favoring or opposing filtration, because interstitial lymphatics should get rid of all the protein. The lymphatic flow is directly proportional to interstitial fluid pressure, and it should pull it out based on what moves lymph. Motor pressure, muscle contraction, all of this moves lymph. So edema is an accumulation of fluid in the interstitial space. Pitting edema is from vascular problems like congestive heart failure. Pitting edema can be fixed with diuretics. Pitting edema is from hydrostatic forces. Non-pitting edema is from inflammation. Non-pitting edema is from anatomy changes. Let's say a person has an axillary lymph node dissection for breast cancer. You can't diurese your way out of anatomic problem. So pulmonary edema is like pitting edema of your lungs. The edema in the interstitium, you can't exchange gas if your alveoli are filled with dirt and goo and gunk. This is edema of the interstitium of your lungs. You get hypoxemic because you can't get gas across. Low hydrostatic pressure in the capillaries should provide protection for this because it should just drain the fluid out. Pulmonary edema is extra hydrostatic pressure in usually the left atrium from left ventricular failure. Left ventricular failure should have back pressure into the left atrium. The left atrium has back pressure into the lungs. So we have no idea how delicate the tissues are of the lungs, like taking a piece of tissue paper and dividing it into 50 thinner slices. It's very easy to get gummed up with water, so that there is no ability to pass gas across it. So, the elevated hydrostatic pressure in the capillary, most common for pulmonary edema, is from this. You have increased left atrial pressure, which increases venous pressure, which increases pressure in the capillaries. Initially, an increased lymphatic flow will protect the lungs by reducing the interstitial proteins, but then it gets overwhelmed. The first sign of it is orthopnea, meaning when you lie flat, you get short of breath, and it's caused by elevated wedge pressure. Wedge pressure is left atrial pressure, and that's bad. You measure left atrial pressure and wedge pressure on a catheter. It's called a Swan-Ganz catheter. This provides the confirmation that you've got bad pressure problems building up in your lungs, and the treatment is to reduce the left atrial pressure, mostly by at first diuresis, later by positive inotropes like dobutamine, Emrenon, Milrinone. Now, the other point about this is that you don't use a wedge pressure in a Swan-Ganz catheter very often, but we have to understand it. Even if we don't use it much, we have to fully understand it, even if we don't actually use it. So this term, ARDS, or acute respiratory distress syndrome, sometimes some people call it adult respiratory distress syndrome to differentiate if that happens in premature babies. It means that I got a direct injury to the alveolar capillary endothelium, or the alveolar capillaries. And it basically means that they're leaky. It's leaky in a wrong way. You see, one of the hardest things that people remember is that gases are supposed to diffuse, but fluids are impermeable. And that means that you have abnormal permeability of liquid, which fills up your alveolar and clogs them up, and you can't breathe. And you get short of breath just as you would with pulmonary edema. And you get respiratory infiltrates, and you have a lung that looks like pulmonary edema, but all the pressures are normal. And it can be caused by sepsis and bacterial pneumonia and trauma and gastric aspiration. And it's protein containing fluid in the alveoli. It inactivates surfactant and it causes reduced lung compliance. And the whole point is it looks like pulmonary edema, but the wedge pressure is normal. So it looks like pulmonary edema, but it's not cardiogenic. So let's look at the blood volume versus the plasma volume. This is a very simple idea. So you take out the cells and that's the plasma volume. Now why that's important is that plasma filters the kidneys. Plasma goes across. Red cells don't. So plasma is only about half of blood volume. The higher the hematocrit, the less the plasma. The lower the hematocrit, the greater the plasma. So plasma volume and blood volume is not always the same because you have to remove the hematocrit to be able to say it's the plasma volume. So what's the difference between plasma and serum? by the way. It's the clotting factor. Plasma has clotting factors and serum doesn't. So thank you for your attention. That's my first video about physiology, and see you in the next video. Tell me in the comments what you like, what you didn't like. Tell me your opinion, and see you.